Hello, my name is Antonio Gutierrez, and I am an assistant professor at Duke University School of Medicine. Today, we'll talk about this quick video tip about best practices to address disparities before and after peripheral vascular intervention. Here are my disclosures. So we're going to start off by talking about ethnic-specific prevalence of peripheral artery disease, PAD. So if you look at the US population, 40 years or older, the prevalence of PAD starts off around 4% in Americans 40 years of age and slowly increases to 10% among Americans in their 70s. However, if you look at prevalence according to ethnic background, you will see some interesting findings. And these are depicted in the figure to the right. On the y-axis, we have prevalence. On the x-axis, we have years. And the blue line depicts non-Hispanic whites. The black line is for African Americans, yellow Hispanics, green Asian Americans, and red American Indians. And what you can see that for each age group, the prevalence of PAD in blacks is twice as much as any other ethnic group. After blacks, the group to have a highest prevalence are Hispanics. And this is actually nationality specific, with Puerto Ricans at 13%, Mexicans 11%, Dominicans 10%, and other Hispanics at 6%. So now that I have shown to you that there's a higher prevalence of PAD among blacks, it's also important to note there's also significant disparity when it comes to PAD among blacks. Overall, they have worse outcomes. This is because they have a worse initial presentation. For example, they have greater symptoms and greater disease severity. This is depicted in the figure to the right. This data comes from the VQI registry looking at 76,000 patients. Here we have 3 disease processes: carotid artery disease, aortic abdominal aneurysm, and PAD. The black bars represent blacks, gray whites, and what you can see for each disease process, blacks tend to present with worse symptoms. For carotid, you have increased stroke. For aortic aneurysm, you have rupture. And for PAD, blacks tend to present more often than whites with critical limb ischemia. Blacks also have higher amputation rates and lower revascularization rates. This is seen in this figure that comes from Medicare data from 90,000 patients. On the y-axis, we have percentage. On the x, we have number of revascularizations prior to amputation. And what you can see that blacks simply get less revascularization attempt than whites when it comes prior to amputation. So let's talk about the etiology of this disparity. Well, for blacks, they tend to have the highest rates of cardiovascular risk factors, such as hypertension, diabetes mellitus, which we know 20 to 30% of patients with diabetes have PAD, smoking, one of the leading risk factors for PAD, and kidney disease. Among Hispanics, high rates of diabetes, and they're less likely to be on guideline-directed therapy. It's also important to note social determinants of health, such as poor access to care, lower levels of education, and lower income. Now, these social determinants of health can be seen in this figure. What you have here is blacks depicted versus whites according to income, less than 40,000, greater than 40,000, and 2 disease processes, diabetes and chronic kidney disease. Right off the bat, you can see that blacks have a higher risk of amputation at 3 years compared to whites. And for each additional disease process of diabetes or kidney disease, the risk for amputation increases. So now that I've mentioned to you about these disparities, what are we going to do to mitigate them? We're going to need a multifaceted and collaborative approach based on the following 3 principles. The first is increasing PAD awareness and facilitating access to care. To the right, we have a map of the United States. It's a heat map, where the darker the shade, the higher the rate of amputation. And what you can see that in the South, Northeast, and Northwest, there are very high rates of amputation. In these areas, in the local and regional communities, physicians need to do a better job either bringing patients in or going out to the patients and letting them know about peripheral artery disease. The second principle is skilled and timely interventions. Here we have the spectrum of peripheral artery disease. On top, we have stable PAD, ranging from asymptomatic to the left, on the right, leg pain and exertion and rest. And then below, we have critical limb ischemia. It's very important to have skilled and timely interventions, especially in patients that present with rest pain, tissue loss, and ulceration. Even though these are advanced stages of peripheral artery disease, these patients are still at a point where they can get help and prevent limb loss. In conjunction with timely interventions, we also need to optimize concomitant preventive therapy. This includes medical therapy, such as antithrombotic agents, antiplatelet and anticoagulation, lipid-lowering therapies, such as high-intensity statins and PCSK9 inhibitors, and glycemic controlling agents. We also need to implement behavior modification, such as smoking cessation, diet, and exercise. The third principle is we need a multidisciplinary collaboration to promote continuity of care. It takes a lot of people to take care of patients with PAD. We have primary care physicians, cardiologists, surgeons, radiologists, wound care, podiatrists. Each has their own specific expertise, and together they provide state-of-the-art treatment. In conjunction with this group providing a timely intervention, they will also help with continuity of care, such that if a patient gets a revascularization, whether in a hospital or outpatient setting, they will still have a good follow-up care system. Once that happens, we also need, in conjunction, to implement prevention to keep from these occurrences. So this may seem like a lot, but actually there are plenty of great examples across the United States right now where people are already doing this. One of such example is in the Veterans Health Administration. The VA has a prevention of amputation in veterans everywhere, the PAVE program. And in this program, any veteran that's at risk for primary amputation, meaning they have PAD, diabetes, kidney disease, or any sensory neuropathy, and especially if they had a prior amputation, they get set up with a team coordinator that gives them access to all these subspecialties. So if you're part of the PAVE program, at minimum, you get a yearly fee check, you get a risk assessment level, and you get a referral strategy from case management that helps patients coordinate care. So let's sum it all up. How are we going to address disparities in PAD? The first is we need to increase awareness. The second is we need skilled and timely interventions. And the third is we need to promote a continuity of care. Thank you very much.